This is the third and final video of the epidemiology of oral diseases. And in this particular video, we're going to talk about oral cancer and fluorosis, and then we're going to circle back and talk about oral health in Kentucky. So let's start with oral cancer. In terms of oral cancer, when you look at all the cancers that we see in the United States, and you look at kind of a pie chart of the different cancers, oral cancer composes about 3% of all of the total cancers in the United States. And we also know that it's about the sixth most common cancer in the developed world. We have about 30,000 new cases of oral cancer, oral or pharyngeal cancer per year. And unfortunately, we have about 8,000 deaths per year from oral and pharyngeal cancer. When you look at the overall 5-year survival rate, meaning how likely it is that someone that has the diagnosis of oral pharyngeal cancer, how likely is it that they're going to live to the 5-year mark? And with oral and pharyngeal cancers, the overall 5-year survival rate is about 50%, meaning about half the people that get the diagnosis of oral or pharyngeal cancers are going to live 5 years or beyond that diagnosis and treatment. And if you look at it in terms of race and ethnicity, this overall 5-year survival rate is much, much lower for African Americans than it is for whites, meaning that African Americans have a less likely chance to live 5 years or beyond than whites in our society. I'm going to come back to gender here in a second when we're talking about oral cancer, but let's talk about some of these other variables. In terms of age, it just like periodontal disease as well as edentulosum typically, age is an accumulation of disease with oral cancer. So it takes a while for our damaging habits to take effect and set us up for environment that would be susceptible to oral cancer. What we do know is that the strong majority of oral cancers occur in people that are 35 years or older, and the estimates are 95% of oral cancers occur in people that are 35 years or older. And we also know that males that are between the ages of 40 and 65 years old have the highest number of lip and tongue cancers. I was trying to combine words there. So males 60 up to 65, 40 to 65 have the highest number of lip and tongue cancers. Tobacco use and alcohol use kind of go hand in hand. Both of them alter the cell composition of the oral cavity. So once it alters the cells and the mucosa, then it is going to make that mucosa more susceptible to oral cancer as well. So in terms of tobacco use, about 75% of the oral cavity and pharyngeal cancers are attributed to smoked or smokeless tobacco. And we have to put alcohol into that kind of category too, because we see an increased use of tobacco sometimes when people are using alcohol. And our tobacco cessation speaker, Miss Temple Jennings, alluded to that. In terms of race and ethnicity, unfortunately, African Americans have the highest rate of oral and pharyngeal cancer, along with the worst survival rates from oral and pharyngeal cancer. As you all know from pathology, the most common area for oral cancer are the floor of the mouth and the tongue. And whites actually have a higher incidence rates of lip cancer, so kind of around the border of the lip tends to be a susceptible area for whites, and it's probably due to the pigmentation of the skin there. In terms of gender, I told you I wanted to come back to gender. Males are about 2.5 times more likely to develop oral and pharyngeal cancer than females, and you can see it in this graph, and it's a rate per 100,000 people in this particular gap, or in this particular chart. But the gender gap really is narrowing. I know it's hard to see from this particular chart, but it is narrowing, and it's attributed to an increased and prolonged use of tobacco products from women. So at one point in time, it was very socially unacceptable for women to smoke tobacco or use any form of tobacco. But in our society, it's, people don't think twice about whether females are smoking or dipping or those type of things. So it would be really interesting here in a few years to see if these rates, if this gap is really narrowing or not. In terms of fluorosis, remember, kind of think back to your theory course. Fluorosis happens when you have a lot of fluoride that you're ingesting. So you have to ingest it systemically to be able to mess with the ameloblast and them laying down the enamel matrix. So think about what phase of tooth development this occurs in. It occurs in the mineralization phase of tooth development. So before eruption, but during mineralization. When you look at the numbers, about a fifth of the school children exhibit very mild or mild classifications of fluorosis. So if you think back to the dental indices lecture, and you look at the Dean's index of fluorosis, very mild or mild classifications just means that they have little white flecks on their teeth. So it really is much more of a cosmetic concern as opposed to a functional concern when you're looking at very mild or mild classifications of fluorosis. And this is because we have a lot of different fluoride products out there on the market. So we have water fluoridation. We, utilize water fluoridation during our food and drink processing. We have fluoride supplements. We have fluoride toothpaste. We have varnish. We have mouth rinses. So we're seeing that the prevalence of very mild to mild fluorosis cases has increased slightly because of all of those different products that are out there, and sometimes those products can be misused and not used appropriately. So let's talk about what's going on in Kentucky. In 2002 was the last time that they've done a adult oral health survey in Kentucky, and it is a little bit dated, but all indications suggest that the data is about the same in Kentucky. So not a whole lot has changed in terms of the adult oral health in Kentucky. What we do know that everything is consistent with what we're seeing on a national level. We're seeing that poor adults within Kentucky have much more active decay as compared to non-poor Kentuckians, so wealthy Kentuckians. We're also seeing that poor adults in Kentucky have had all their teeth extracted and are edentulous, and hardly anybody within our wealthy group is edentulous. What's really interesting is about a quarter of the population have reported that they've had some type of oral pain in the recent past, so within 3 months. But when you break down that data and you look at the categories of people that are reporting the oral pain, almost half of that are people that are Medicaid recipients, meaning that they fall below the federal poverty level. aka they're poor. So what you can conclude from that is that poor Kentuckians, um, there are a lot of poor Kentuckians that are reporting that they're having oral pain, and they've had it within the last 3 months. And then about half of our poor Kentuckians rate their oral health as poor compared to our wealthiest group. So our wealthiest groups are reporting and think that their oral health is in good condition or excellent condition, but our poorer Kentuckians don't see it that way at all. So I want to circle back to some other data. So in Kentucky, this is KentuckyHealthFacts.org, and this is utilizing the BRFSS data from the CDC, and they have mapped out our people, the groups of people that have had significant tooth loss. So they're missing 6 or more teeth, typically from periodontal disease or from carious lesions. And you can see that the places like Jefferson County and the Louisville metro area, Fayette County, and even northern Kentucky, and I think that one little yellow place that is down in southern Kentucky might be around Bowling Green area. Those are areas where there are less of the population that are missing 6 or more teeth. So whenever you're looking at for the dark purple or the dark blue areas, we're seeing eastern Kentucky, southeastern Kentucky, they're having significant amounts of their population that are missing 6 or more teeth because of carious lesions or periodontal disease. So I want to, like I said, come back to the Louisville Metro Health Equity Report that was done in 2017. And when you look at the report, they have broken it down based on age categories. So they have kind of infants, and then they have youth, and then they have young adults, and then they have older Louisville Metro members and whatnot. So they've broken them down by age categories, and then they look at some of the health outcomes that are significant within that particular age category. And oral health actually came up as one of the very significant health outcomes for the youth population of Louisville, Kentucky. So they have a whole section on oral health and youth in the Louisville metro area. So this was the first, I took a screenshot of this section for this for you all, so you don't have to look it up. But this is the very first part of that section, and it's defining oral health, and then it's talking about how oral health affects your systemic health as well as your quality of life. So you can read kind of through that if you would like. The second page on that particular section is talking about and listing the data out. So it's looking at the JCPS kindergartners and then first graders that have been screened. And it's looking at the amount of cavities that that particular population has. And they plotted it out ever since 2012. So if you're looking at the bottom graph here, the blue line is kindergartners. We've had a significant increase of kindergartners that have had cavities once they've been screened for kindergarten. So, over the years. So in 2012, 2013, it looks like it was about 2% of the kindergartners. And then in 2015, 2016, it was up a little over 12% of the kindergartners had active decay. The other graph right above it is talking about whether kindergartners or first graders have had that dental screening or not. So we have mandatory dental screenings for kindergartners entering the school systems, but unfortunately, and Dr. McKee can talk about this whenever they meet with us during our Zoom meeting, but unfortunately, that policy really doesn't have any teeth, and we can't hold people accountable for it because Kentucky just doesn't have the money or the resources to give that policy any teeth and make people abide by it. So they're actually collecting the data to see how many kindergartners or first graders haven't gone through that screening process. The bottom part of this particular screenshot is talking about the root causes. So think about the picture of the tree at the very beginning of the first video of this lecture. And the root causes that they've identified that really has impacted the youth's oral health is the Health and Human Service cause, food systems, and then environmental quality. On the next page, they actually go into those root causes and gives a lot more description about the root causes and how that impacts the oral health of the youth. And then finally, and I know a lot of you all have actually talked about this in your exit tickets, best practices. What can we do to help this particular population improve their oral health outcomes? And in this health equity report, it really breaks it down in terms of what individuals can do, what an organization can do, what a community can do, and what can we do on a public policy level. So of course on an individual level, we can teach them how to brush and floss, the value of fluoride, and the value of going to see the dentist. On an interpersonal level, keep encouraging to do oral health routines, and keep kind of that social pressure on going to the dentist, as well as educating people of when the appropriate time to start taking children to the dentist would be. On an organizational level, you can start thinking about changing the food in the school system. You can think about hopefully increasing school-based oral health services. So maybe they could start sealant programs as in addition to fluoride programs. We could also educate primary care providers, and hopefully we can get pediatricians on board to do oral health examinations, especially if a child doesn't have a dental home. Typically they have a pediatric MD home, so hopefully they could cover that base of oral health and doing a screening in there. And then continuing to provide oral health education programs to kiddos. That would be very, very helpful. On a community level, they suggest joining the Kentucky Oral Health Coalition. The Kentucky Oral Health Coalition has really done great things for Kentucky's youth, and in particular for dental services for Kentucky's youth. And it is, I'm a member of the Kentucky Oral Health Coalition, and it's pretty cheap to be a member, and there's always power in numbers. So, they hold CE programs, and they also hold advocacy things at Frankfurt, typically in February, because that's Children's Dental Health Month. And then you can see some other suggestions that they make. On a public policy level, to continue community water fluoridation is the biggest one. It's the big bolded one that we want to continue in Kentucky. If we can enforce the mandatory oral health screenings, for kiddos. If we can actually make teeth into that policy, it would be really great. Um, as well as making sure Medicaid, Medicare, and private health insurances cover oral health care services, especially screenings and preventive services. So those are some of the suggestions that the Louisville Metro Public Health Department have suggested in order to improve Kentuckians and specifically Louisville members' oral health. But as you can see, there's always some gaps, and we're always going to be working towards better oral health overall. So these are just a stepping stone, and of course, the public health department is going to be increasing as well as inserting new best practices out there and new goals and new objectives. So, in summary, people that have the poorest overall health, I think that you could probably see the trends here. People that are racial or ethnic minorities, so non Hispanic blacks, Hispanics, American Indians, and Alaskan Natives tend to have the poorest overall health. If you are looking at income, people that are low income tend to have the poorest overall oral health. People that have less than a high school education, so that they don't have a high school degree, much less going to college, they tend to have the poorest overall oral health. And then in terms of gender, males tend to have the poorest oral health issues, with the exception of edentialism. And there wasn't a gender difference, a significant gender difference on edentialism. So that it wraps up our epidemiology section in lecture. So as you can see, there are certain segments of the population that are more prone to have oral health issues, and you can see that those trends are consistent over multiple oral health issues overall. Oh, almost forgot. Your exit ticket is if you go to www.socrative.com, and the room name is CDH1 Lecture 7. Sorry, I almost cut off the video there.